Good afternoon, dear colleagues. My topic is about biological effects of materials and prosthetic design on the peri-implant tissues. I'm Péter Tajti from the Department of Prosthodontics, and my vision is to provide the best treatment for my patients in implant rehabilitation. Therefore, my mission is implementing the fully digital workflow in every aspect of it. To reach my goals, I have these two projects, from which the first one is about two restoration materials and the comparison of them. So for many years now, in prosthodontics, the golden standard restoration material is metal ceramics. They have an excellent survival rate over a long-term period, as we can see, as implant restorations. Later, other ceramic materials showed up, and they could be manufactured with CAD/CAM technology for more precise and aesthetical frameworks. However, these frameworks need to be veneered with other types of ceramics. The main problem with these ceramics, veneering ceramics, is the relatively high chipping rate as a technical complication. So it is also important to mention that these restoration types can either be cemented or screw retained, because these factors can affect the biological and technical complications. In order to minimize the technical complications, a new material was introduced, and this is called Monolithic Zirconia. So monolithic restorations allow to avoid this technical sensitive veneering process, and thus may result in better outcomes. So they have several advantages, like they have favorable biological effects because of better cell adhesion and low plaque accumulation rate. They have no chipping of the veneering ceramics, and they are really promising regarding aesthetics in the posterior region, and because of the ability for CAD/CAM processing, they have high accuracy as well. So these materials have actually results following these restorations, but there isn't any comparison whether they could be a good alternative to the golden standard metal ceramic. So therefore our aim is to investigate the benefits of using monolithic zirconia restorations. So this is our question: how do they perform in clinical outcomes? And our hypothesis is that monolithic zirconia restorations can be a valid alternative to metal ceramics. This was our systematic search in the following databases, and after the selection process, we've got 4 eligible articles. The first result is about marginal bone loss, which is important because bone gives the stability for the implants and the soft tissues as well, and is measured in millimeters with a probe. So we can see that the common effect is minus 0.11, which means that in the monolithic zirconia group there were 0.11 millimeter less bone loss. However, this is not statistically significant nor clinically. It is also important that all of our records were RCTs with the same methodology, and actually, I-square tests shows low heterogeneity. The next result is bleeding on probing occurrences, indicating soft tissue health, and is measured by a periodontal probe. Here we can see that the odds ratio is 0.66. That means in the monolithic zirconia group there were approximately 1/3 less bleeding occurrences, but because of the short-term follow-up period, this is not clinically relevant. Our third result is about chipping. This is important regarding the aesthetics of the restoration. We did 2 analyses. In the first analysis, we included all 4 articles, and we can see no statistical significance. But we can see in the Mangano article there was 1 chipping in the monolithic zirconia group. This was because the patient was a bruxist. So we actually excluded this article and did another analysis, And in this second analysis, we can see statistical significance between the two groups. In the monolithic zirconia, there were approximately 90% less chipping. And our last result is implant failure occurrences. This is very rare, but a very important outcome. Here, the analysis showed no significant difference between the two groups. So we can say that our strengths are that all of our articles were RCTs with we have no other meta-analysis in this topic, and we have high certainty of evidence for every outcomes. However, our limitations are the low number of studies, the short-term follow-up period, and we had some heterogeneity among the patients. We can say that at 1 year follow-up period, both restoration types were similar regarding the bone loss and the bleeding. And in the monolithic zirconia group, there were less chipping over 1 year. So our hypothesis was true. Monolithic zirconia can be a valid alternative option as a restoration material. If we use these materials, it would mean more predictable restorations, and the soft tissue adaptation may be better to these materials, and also would mean quicker production overall. But we need more studies in this field with medium to long-term follow-up periods, and all of the studies should involve biological outcomes with volumetric changes of the mucosa, and we need more detailed inclusion criteria and more homogeneous populations. Currently, I'm at the manuscript writing process. Moving on with my second project, this is about different implant placement levels and the comparison of them. We know that hard and soft tissues are crucial for the stability, for the long-term success of the dental implants. After placing the implants, soft tissue has to form the attachment around the implants, and this attachment needs place vertically and horizontally as well. So there will be an unavoidable marginal bone loss. Now, not only in the first year, but after the first year, and this bone loss is influenced by many factors, as you can see. For example, soft tissue thickness, the abutment micrograph, macro design, and prosthetic components, and also the vertical positioning of the implants. So this could be either subcrestal or epicrestal, and actually the most recent studies, there is a big controversy that whether subcrestal placement is really significantly better over epicrestal. So our aim is to investigate these two placement levels and their influence on the crestal bone and the soft tissues. Our hypothesis is that subcrestal implant placement may reduce marginal bone resorption. This would mean, this would determine the best placement level for the surgeons, preserving more bone, and would result in actually more stable tissues as well. This was our systematic search, and our preliminary selection gave us 12 eligible articles so far. I would like to finish my data extraction in April, and my main aim is to finish my first project until March, or in March actually. And I would like to thank you for your attention with this quote: "If we knew what we were doing, it wouldn't be called research."
At the end of your first presentation, you mentioned you are going to establish subgroups. So actually, in that time, have you answered my question? You don't know my question, but let me explain. So you compared monolithic zirconia versus ceramic fused to metal, but you didn't investigate yet whether they are screwed or cemented crowns.
Yes, thank you for your question. Unfortunately, because of the low number of studies, we cannot do subgroup analysis regarding the retention types, but yes, this is a very important aspect.
Because it most likely this is the most important question about the plaque accumulation.
Yes.
In your first project, you mentioned in the limitation the heterogeneity in the population. How different are they in which aspect?
There were heterogeneity among the included patients, for example, regarding temporomandibular disorders. So there were studies that included patients with these temporomandibular disorders, like bruxism, but other studies did not, for example. And also there were heterogeneity among the retention types, as I mentioned, the cemented and screw retained, also very important.
Okay, thank you.
What is the clinical implication of this, the first project?
Well, the clinical implication, so actually this, as we could see, this is a good alternative material, so dentists can use it. It would be more predictable. It is easier to redo these materials because of the CAD/CAM technology. Yes.
I have a question regarding your first project. So both kind of implants are used on a daily basis in clinical practice, right?
Yes.
And is there any contraindication or general disease that you wouldn't recommend one or the other one for the patient?
Actually, there are no general disease that can influence. So it's really on the dentist and the patient's choice, communal choice, which material would be best for the patient. Thank you.
So based on this, actually I asked kind of similar question as was before. I'm just repeating that in some ways. So based on this, actually, which one are you going to use first line of the two different kind of materials?
So
is there any indication which actually brings this new one, the ceramic one, compared to the old one?
As we saw, this could really minimize the technical complications, as they have no chipping. So I would gladly choose zirconia, monolithic zirconia. However, it is also important to mention that these were in the posterior region. So monolithic zirconia is not yet so aesthetical than veneered zirconia. So if we are investigating aesthetic region, I wouldn't choose monolithic over the veneered zirconia.
Yeah, and also, I mean, since in the dental procedures usually paid by the patients, so how about the financial side of this?
Yes, financially, the golden standard metal ceramics are, of course, more cost efficient or more cheaper than monolithic, because monolithic is a new material and CAD/CAM technology is more expensive than the other.